Developmental conditions and other psychiatric conditions can also present in the early age. In fact, the mood disorders are one of the common differential diagnoses for schizophrenia even in the adults. Sometimes you will not know clearly whether it is a mood disorder with psychotic symptoms or a schizophrenia till late in the course. Okay, only if you see the longitudinal picture, you will be able to make a clear diagnosis. When it is an acute presentation, especially in the adolescent age, we will not be able to clearly differentiate between mood disorder presenting with psychotic symptoms and primary psychotic disorder like schizophrenia. Okay. Sometimes PTSD, especially when there is a clear trauma in the background, okay, and re-experiencing phenomena along with other depressive symptoms can present as a psychotic-like condition, but there will be a clear trauma where the child is affected by the trauma. The re-experiencing phenomena can present as hallucinatory behavior. OCD, especially when the child is having premorbid intellectual functioning or intellectual compromise, when they have OCD, they may confuse between thoughts and perception. Okay, thoughts means they get frequent obsessions. Perception means there is a hallucination. Sometimes they report thoughts as perception. I am hearing, I am seeing, but it will actually be thoughts. Okay. So again, this is one of the differential diagnoses has to be considered in adolescent age. Anxiety disorder, again, they may report as perceptual abnormality and with other restlessness and anxiety symptoms. But again, anxiety disorder is little easy to differentiate from psychosis. OCD is sometimes complex to differentiate from psychosis initially. Only as it evolves, we'll be able to differentiate. Anxiety disorder is easy to diagnose. Developmental disorder like autism and ADHD sometimes is confused. ADHD, there is not much overlap except some disorganization will be there. There won't be any positive symptoms which will be seen in ADHD, so it is slightly easier. But autism spectrum disorder, sometimes it is difficult to diagnose because there will be lots of negative symptoms like picture because they are asocial, they won't have much social interaction. But here in autism, this pattern you will see from the beginning, but in psychosis there will be a clear onset. If there is a clear asocial behavior or lack of social interaction from the beginning, then you have to suspect a developmental disorder like autism spectrum disorder. But if there is clear onset, suddenly start withdrawing where there is a clear social preserved social behavior premorbidly, then we have to consider schizophrenia. And also sometimes in children with autism, because of the poor socialization, they will have lots of imaginary friends which will be confused with hallucinations. Okay, this we have to be very clear because they may be reporting, I am talking with my friend, I am seeing my friend, but if you see when you talk with them with serial MSc, it is just imagining because everybody rejects them, they want to interact but nobody accepts them because of lots of clumsiness and other social skill deficit. They develop an imaginary friends which actually may not be a hallucination. Okay, so here with these two things we have to differentiate autism spectrum disorder, especially high functioning autism spectrum disorder from schizophrenia. So these are the differential diagnoses we have to consider, especially in the early onset schizophrenia. So evaluation, a comprehensive history and history from the multiple informants and developmental considerations, as I was mentioning, should be part of any clinical evaluation. Rating scales and structured interview can support clinical diagnosis. This is only supportive. Like initially we should have a high index of clinical suspicion. This is a support for a clinical diagnosis. Rating scales and structured interview used in adults can be used in adolescent and childhood onset as well. Okay. And cognitive assessment is not part of diagnosis. You don't require cognitive assessment for the diagnosis, but to ascertain the prognosis and to find the comorbidity, especially developmental comorbidity, you can do a baseline cognitive assessment and then follow up with yearly or 2 yearly cognitive assessments where you will know whether the patient is responding to treatment or not. So, rating scales or structured interview is to support clinical diagnosis. Cognitive assessment is not required for the diagnosis but to prognosticate and to find the comorbids. So all these things along with the relevant medical workup should be part of the evaluation of early onset schizophrenia. So medical workup, routinely these things are done in most of the centers, especially when you are planning to start the child or adolescent on medication. Complete blood count, liver, renal function, thyroid function, metabolic parameters like sugar, BMI. Okay, ECG and BMI evaluation should be part of baseline workup. It is very important to know the side effects of medication you prescribe, and this routine blood workup will give some clue about any underlying organic condition manifesting as psychosis. Common conditions like endocrine abnormality. Okay, in select cases, neuroimaging or EEG is not recommended for all the cases with early onset psychosis, but in select cases when there is a clinical suspicion, when you suspect tumor or encephalitis, do EEG and neuroimaging will help. Neurometabolic workup, especially in the very early onset, children less than 12 years, especially when there is an episodic pattern. Along with the other pointers, you have to consider neurometabolic workup, where inborn errors of metabolism and other mitochondrial disorders are considered, especially in a very young age. Later age group, especially after 12 years, the neurometabolic workup will generally be negative because it will present much earlier. Porphyria, especially when severe abdominal pain with a psychosis in episodic pattern, with lots of autonomic fluctuations, you have to suspect porphyria and send for urine phosphobilinogen. Copper and spherinoplasmin, when the LFT is affected, only neuro-Wilson is very rare. Okay, neuro-Wilson only with normal LFT is very rare. Usually the liver problem will be the first manifestation, especially if we do a LFT. If it is abnormal, we have to consider copper and ceruloplasmin. This is very important, especially in the background of cognitive deficit. If the cognitive deficit is out of proportion to other symptoms, we have to suspect Wilson. Toxicology screen, as I was telling, in older children and adolescent age where you suspect drug of abuse, we have to do toxicology screening. These investigations are not required in the routine clinical workup, but if you suspect, if there is a clinical suspicion, you have to do these investigations.